identified yet because we know from the patterns. Okay? Next one. So there are inherited ones. I wanted to touch on pancreatic cancer a little bit. It's a terrible disease. It goes up with age, as you can see here. There are about 40,000 cases a year of pancreatic cancer, and the death rate is about 38,000. So 95% of patients with pancreatic cancer die from pancreatic cancer, no matter when you catch it. Even if you catch it dead early, most of those patients are going to die. So it's a horrible disease. Next slide. So even if you catch it early, the average survival is only 2 years. And if you catch it metastatic, stage 4, 4.5 months. Okay? Turns out not true. Not true anymore. Mel told you about one of his cases we shared together who had pancreatic cancer and is now approaching almost 2 years with metastatic pancreatic cancer. And I have a woman who is still going 4 years after it, and another woman who passed away 22 months after it. So we're seeing much more. Is it great? No, but at least we can buy these people some time. And it's with standard chemotherapy. It's playing with chemotherapy, different kinds of chemotherapy than we've used in the past. And for the first time, we have something to offer these patients. Is it great? No. They're still, almost all of them are going to die of their pancreatic cancer. But we can, and there's no way to test for it. There's nothing you can do to identify it. Next.
Later.
Okay, so we started with standard chemotherapy. Now, chemotherapy is like bringing a cannon to the party. You sort of blast everything and hope something happens. So how come chemotherapy works at all? And the reason is that cancer cells, as powerful as they are in killing people, are defective. They're not normal cells at all, and they can't repair themselves if they're damaged. So what you do is you bring to bear something that is poison to most cells, or many cells. The normal cells will recover. The cancer cells will not because they're defective. It's a big cannon. I don't like, if I never used chemotherapy again in my lifetime, it would be too soon. But it's invaluable for certain diseases. Lymphomas being one of them, leukemias being another one. There are all kinds of diseases where chemotherapy remains the key, and in pancreatic cancer, it's starting to make inroads. But we need much better treatments than we have now. So I'm going to tell you about a few of these, just as examples to what's coming down the road, because if we stayed here for 2 days, I couldn't cover all of the things going on now in the cancer business. It's enormous. But I'll tell you the story of the Philadelphia chromosome. See that little nubbin at the bottom? I'm not sure how many of you can. But this is the chromosomes that we all have. And it turns out that a little bitty piece of a chromosome was identified in Philadelphia. And it's called the Philadelphia chromosome for that reason. And it's found in patients with chronic myelogenous leukemia, and it is the cause of that disease. If you close off the problem with this chromosome, you shut down the disease. Okay? That was known by a experimenter paid for by the government, and the government grants. I love the Republicans, we don't do any good from the government, but here's government research, government-funded research. The guy came to Novartis and pleaded with them, please make an inhibitor of the result of this chromosome. And Novartis tried for a while and gave it up, said it's bullshit. Okay? And the guy went back to them and said, try some more. Next slide. And they came up with something called Gleevec. Okay? Gleevec is a pill. There are 5,000 patients with chronic myelogenous leukemia. Survival used to be 3 years. You give them a pill once a day, and nobody dies from this disease anymore. Really? It's just a miracle. What happens is it blocks the active part of this chromosome change that causes the disease. And I won't go into the chemistry of it, but I can tell you that it's a very simple pill to give with very few side effects. And there are now 4 other pills, because what happens sometimes is that there are mutations. These cancer cells are very smart, and they will mutate, they will change, so that the Gleevec doesn't bind to the site that it needs to bind to. So they've now developed 4 more pills that work in the same way. And I just have not seen a patient even close to dying of chronic myelogenous leukemia in about 10 years, whereas they used to live 3 years. So a major step forward. It would be nice if we had that for every cancer. Turns out we don't. Next slide, I'll show you one that we do have it for. No, that's another slide. We'll talk about another one in a little bit. So this is the first example of how gene information was turned into a cure for cancer. So everybody's hot to do this. Memorial just published, it was in the Times and published in the New England Journal of Medicine. They have sequenced the whole gene of 200 patients with acute leukemia. 200 patients. And they got gibberish out of it. Mostly gibberish. They can't identify targets from it. There are a few good identifiable chromosome changes, but there's nothing I can go to my office tomorrow and pull off the shelf like Levac and give it to a patient with acute leukemia. That doesn't mean we're not going to find more, and I'll go back and show you an example of another one in a little bit. But gene therapy is coming, and the gene and genome treatments are going to be critical to the future of oncology. But today, we still have a lot more work to do before we make any sense out of these changes in the genome. But I can tell you, you can now get a genome, your gene, my gene, sequence, the entire sequence done for about $10,000, and the price is coming down and down and down. So we're going to know what's in our genes in a few years. How much that's going to help us cure cancer is another issue.
Okay. Let's say a couple gets married and they want to know what the next one's experiences are. You believe in certain testing?
Well, there are certain things we have to test for, but not cancer genes. That's not ready for prime time. Here's another approach that's new and that's been very valuable. You know about Rituxan. One of your member of the audience was telling me he's being treated with this drug. What is it? It's an antibody. We love to use immune therapy if we can. This is an antibody that's used in lymphomas. It's also used in immune problems, but that's another story. In lymphomas, it's changed the face of lymphomas. It attacks only particular cells, so it doesn't contaminate the whole body like chemotherapy does. It specifically attacks the lymphoma cells. It's what's something we call a monoclonal antibody, which means that it's very, very pure. It goes after one single site on these groups of cells, and it's made a huge difference in some of our lymphomas. The difference, for example, in Burkitt's lymphoma, which is a very fast-growing cancer, kills people overnight, 24 hours, 48 hours, and they're dead.
Which one?
Burkitt's lymphoma, discovered originally by Dr. Burkitt in Africa, but it happens in this country. Very fast-growing cancer.
What kind of lymphoma is it?
The lymphoma. It's a B-cell lymphoma. It's all over the body. But anyway, the chemotherapy was 20 or 30% cure rate. We added Rituxan, and it's now an 80% cure rate. So this is a tremendous advance in the treatment of that disease. So that should go to antibody. What about other antibodies? Next slide. Doesn't show well, but this is a drug called Herceptin. Herceptin is for certain, about 25% of all patients with breast cancer have an over-amplified growth factor we call HER2/neu. So it makes this growth factor, which turns on the cells, actually makes a very nasty form of breast cancer. I was there when this went down many years ago. Go to the next slide, I'll come back to this one. Yeah, I was in the audience in 2004, 2005. There were 10,000 oncologists in the audience, and the data were broken on this test that was done. Half the patients who had been diagnosed with breast cancer, had it removed, half of them were treated with Herceptin, and half were not. And this huge difference in survival, by our standards, they cut the relapse rate by 2/3. The place went crazy. It was like a rock concert. We don't see things like this very often. So this antibody is capable of curing women who would otherwise relapse from breast cancer. So it's a very good antibody. Not perfect. Next slide. What happens is that people the people doing this research are getting clever and clever. The Herceptin by itself is very good, but I have patients who are on Herceptin, they have metastatic breast cancer, and they fail. And then I'm out of business, except not anymore. You may have seen this. It was the lead article in the American Society of Clinical Oncology meeting last year. What they do is they take Herceptin, which attacks HER2/neu, and they hook it to something called maytansine. Maytansine is a poison. It attacks a cell and kills it. It was tried as a chemotherapy pill. It was too toxic. But they hook it to Herceptin with a special splicer. So the Herceptin marches up to the cancer cell and says, let me in, binds to the cancer cell, and then unleashes